tumors. So we will start ovarian tumors. It will run in 2 sessions because as you see how big the ovarian tumor nodes is in Kurt nodes, and honestly, it is. It's very high yield, and you get a lot of questions on the ovarian tumors and adnexal tumors in the boards and in the Q banks for the boards. So you need to know a lot of stuff. Not a lot, but I tried to make it even more easier for you guys. So what I did in this notes is so if you look at there, so he also updated the notes for the ovarian tumors recently, so last month. So I have the notes, which the version which was before that, it was back in 2020. So he updated it recently. So this thing is following the recent guidelines, which is very good. So as you see, I tried to have some handwritten areas added to make it easier for you. And I tried to add some mnemonics here. And also when it comes to tables, I try to already add by my hand what you need exactly to know from this table. And also, I tried to put the key microscopic feature on each picture so that if you're planning to do a fast review or just go over ovarian tumors really fast, all what you need to do is to go over these key microscopic facts and go over whatever I highlight. Like whatever I highlight is the additional information that you need to know about this entity, aside from the key microscopic fact and being able to diagnose it or spot diagnose it. So you got it. This will make it very easy for you, like to go very fast over ovarian tumors, maybe 4 or 5 times. So it will make it easier for you to memorize everything, and you will see how much you will improve when it comes to an interpretation of an ovarian tumor. But just letting you know first, let's go over the first page. This page he added in his new version. It was not there in the previous version of the notes, so he decided to add the non-neoplastic lesions. Thank you. You get these non-neoplastic lesions in your practice. However, they are not boardable, but you might get one every now and then in an ovary, like in a section that you submitted for the ovary, and the attending will go over it under the microscope and tell you, do you know what this or what this is? So we have some of the benign cysts which might exist in the ovary, including this cortical inclusion cyst and the follicular cyst and corpus luteum cyst, which is always or nearly always hemorrhagic. They call it sometimes hemorrhagic corpus luteum cyst, and some pregnancy-related lesions. I won't go over them. I will leave them to you to read, but just I will go over the 3 benign cysts. So in cortical inclusion cyst, you will see fallopian tube lining, single layer of a fallopian tube-like epithelial lining, very benign, very bland. He's telling you also that in some areas you might see flat/cuboidal lining, which is also a single layer. However, please stick to the tubal type epithelium and look for this ciliated tube-like epithelium in the cyst lining. It's usually very small, to call it cortical inclusion cyst, because sometimes you will ask a good question, an excellent, well, why we don't call this serous cystadenoma? Like benign lining, non-mucinous cells, It's serous cells. Why don't we call it serous cystadenoma? Because of the size. So in the cortical inclusion cyst, you will see that the size is less than 1 centimeter. But in serous cystadenoma, you will see that the size is exceeding 1 centimeter. So this one you will have like 0.5 centimeter, 0.4 centimeter, very small cyst that you found when you are cutting the ovary or serially sectioning the ovary. Okay, I submitted a representative, and under the microscope, I see a cyst lumen, and I see a single layer of tubal-like epithelial lining with some areas showing some kind of flat or cuboidal lining. It's commonly very incidental, commonly in the cortex of the ovary, and it's called benign cortical inclusion cyst. Follicular cyst on the opposite side. Some attendings, they don't care whether you call it follicular cyst or corpus luteum cyst, honestly, because both of them you will have luteinized cells. Luteinized cells means that you are having cells which look like they are having some kind of progesterone effects or LH effect on them. It's just, it depends. Like some attendings, you call it follicular cyst, you call it corpus luteum cyst, you don't care. But my attending, Dr. Han, she's the GYN pathologist, as I told you, in our department. She differentiates them honestly by, she never calls corpus luteum cyst except if there is hemorrhage inside the cyst. They call it hemorrhagic corpus luteum cyst. Or if the lining of the cyst is very, very stratified to the point that the epithelium is showing some kind of wavy lining. Like, because of the extensive stratification, you end up having dome-like projections in which the stratified epithelial lining of the cyst is just throwing out some thick fronds inside the cyst. So see, undulating. That's what I mean. If it's undulating and the lining is very, very stratified, she sometimes call it corpus luteum cyst, and it's usually very huge or large, maybe more than 3 centimeter, with common hemorrhage inside. Because what happened in corpus luteum cyst is there is a ruptured corpus luteum or a ruptured Graafian follicle, and the ovum got picked up by the fallopian tube, but the remaining corpus luteum did not degenerate. If it did not degenerate, it just remained there, formed some kind of cyst, and collect some blood because of the ruptured follicle, and it retains some hemorrhage, forming some central hemorrhagic area that you'll find in the middle of the cyst, with some like stratified lining and undulation. It's usually grossly looks yellow, like a corpus luteum. That's what qualified as a corpus luteum cyst. Otherwise, if you don't see that much stratification, see, there is stratification here, but not that thick. See here, you might count more than 10 to 15 layers here. But here, it's a maximum, you'd say like, oh, well, this is even more than 20 layers. But this, you might say 10, 15 layers. So it's less thick in terms of stratification, but still the cellular lining is the same. You have some bland, benign looking epithelial lining with just some luteinization. Follicular cyst is usually around 4 centimeter, but it's usually less than 8. But corpus luteum cyst might get very huge or very large, especially with the collection of blood or hemorrhage inside, to the point that you see it grossly in the ovary, as you see right there. This one, I believe it won't be less than maybe 5 centimeter with this area of hemorrhage inside. However, benign looking cysts. So in the benign cysts of the ovary, if you want to collect, so you look at the lining. If the lining is a single layer of tubal-like epithelium with cilia and some areas of flat cuboidal epithelial lining, that's cortical inclusion cyst if the size is less than 1 centimeter. But if the size is more than 1 centimeter, you might call it serous cyst adenoma. However, as you see stratified lining, see how thick the stratified lining is. It's very, very thick with undulations and hemorrhage inside the lumen. That's hemorrhagic corpus luteum cyst. Or is it just less stratified with no hemorrhage inside and just you see the epithelial lining or bland, benign looking epithelial lining with some focal luteinized cells? This is follicular cysts, and the other one is hemorrhagic corpus luteum cyst. Okay, so thumbs up for the benign ovarian cyst. We don't want to spend a lot of time on this because we have a lot to do. We have the ovarian tumors. This is very important. Now, here come the boards. Here come the boards. So the classification of the ovarian tumors depends on how the histology, honestly, of the ovary looks like. So when you look at the ovary histologically, you will see the covering epithelium or the surface epithelium of the ovary. And then you have the germ cells. The germ cells are the follicles, you know. So you have the follicle with the surrounding cells, which include granulosa cells and theca cells, as we know. And then you have the connective tissue of the ovary, which is the stroma. So if you classify ovarian tumor, you will end up having tumors coming from each of these three structures. So that's why we have germ cell tumors coming from the germ cells, which include the follicles and the surrounding follicular cells. And then epithelial tumors coming from the surface epithelium of the ovary. And then stromal tumors coming from the stroma. And they call it sex cord tumors. So sex cord are the same as stromal, and the S come with the S. So sex cord, stromal, so that you remember that sex cord are the stromal. And aside from these three key categories, you have a fourth one, which is METs, which is there everywhere in any organ. Any organ, we have the metastasis that might possibly come from elsewhere. Let's start by classifying each type and mention the subtypes under each category. You have 5 and 5. So you got 5 plus 5. 5 germ cell tumors that you need to know, and 5 epithelial or surface epithelial tumors that you need to know. And you need to put this in the back of your mind that the most common subtype or the most common category of ovarian tumors is the epithelial or surface tumors. That's why we will start by covering these entities, because how many ovarian cysts you get every day in your grossing day in GYN? Oh my God, a lot. We get a lot of oophorectomies for ovarian cysts. Some of them are serous cystadenoma, borderline serous, high-grade invasive serous carcinoma, or invasive serous carcinoma, mucinous. These kind of things we get a lot in our daily grossing and in our daily practice. And the germ cell tumors, we have also 5 entities that you need to know, and we will cover the stromal tumors later, or the sex cord tumors later. Let's start by helping you memorizing each 5. Let's start with the 5 for the germ cell tumor. So you need to remember that germ cells means follicles, and follicles means ova, and ovum means that there is a sperm and ovum who meet together and form an embryo. And the embryo always have these 3 layers. What are the 3 layers of the embryo? We have ectoderm, mesoderm, endoderm, right? And it has also a yolk sac. Remember, there was a yolk sac in the embryo, in the structure, and it has its own placenta. So this is the easiest way to remember the 5 entities of the germ cell tumor. Like, see, we have germ cells which are the ova, the egg. So it's tumor coming from germ cell. This germinoma. Okay, very easy. And then we have the ova or the egg meet the sperm, and they form an embryo. So here we go. The second one is embryonal carcinoma. So this germinoma, embryonal carcinoma. And then once you form the embryo, you have three things that you memorize in the embryo, that you have three layers in the embryo from which all the organs are derived, which are ecto, endo, and meso. If you remember ectodermal, endodermal, mesodermal components, so you remember this teratoma thing that has components of the all three germ layers of the embryo. And you have the yolk sac, so yolk sac tumor, and you have the placenta, the tumor coming from the placenta is choriocarcinoma. So very easy to memorize. Memorize the germ cell forming an embryo with placenta, three germ layers, and yolk sac. You'll be able to memorize the 5 entities. And then the epithelial or surface tumor. What are the 5 entities? I always have a mnemonic for this: clear, water, and mucin in the bladder and endometrium. Clear, water, and mucin in the bladder and endometrium. So clear, this makes you memorize clear cell carcinoma. Water makes you memorize serous. Mucin make you memorize mucinous. In the bladder-like tumor. We always remember this, the bladder-like tumor, which is Brenner tumor, and endometrium make you memorize endometroid carcinoma of the ovary. So we have 5 entities that you can memorize using this mnemonic: clear, water, and mucin in the bladder and endometrium. Okay? Terrific. So we have the 5 and 5, and we will start by covering these 5, which are the epithelial. And he put the key microscopic finding in each one on this diagram. This is very good, but let's go one by one. But before moving on and talking about the epithelial or surface tumor, I need you to know from this page that we're dealing with 3 main entities in each subtype. In most of the subtypes, or nearly all the subtypes of epithelial or surface tumor, we will have 3 flavors. First flavor is the benign flavor, and the second flavor is the frankly malignant invasive flavor, in which there is invasion in the ovarian stroma. And then there is a kind of flavor sitting in between the benign and malignant, is borderline, in which the cells are showing malignant features and throwing in some papillae and extensive growth. However, they're still not invading the stroma. So that's called borderline. So we have 3 flavors in each one: benign, borderline, malignant. Let's apply this. So let's say we talk about serous epithelial tumor, where we will have benign serous cystadenoma, borderline serous tumor, and serous carcinoma. Okay, if we talk about mucinous, well, we will have mucinous cystadenoma, borderline mucinous tumor, and mucinous cystadenocarcinoma, which is the malignant. Brenner tumor, we will have Brenner tumor and borderline Brenner and malignant Brenner. Clear cell tumor, we will have clear cell, a benign clear cell cyst, or clear cell, benign clear cell tumor, and borderline clear cell, and malignant clear cell. Endometroid, same thing. So we are having these 3 flavors that apply to all the epithelial or surface tumor, most of them. Okay? I don't care about the older terminology and the newer terminology and these kind of things, but I care about this table, that you need to know that serous tumors most likely present, the serous and mucinous tumors most likely present as benign. So if you are getting an ovarian cyst, excised, or if you are getting an ovary removed, and you have an ovarian cyst and you need to submit sections for frozen or submit sections for permanent or whatsoever, if it's serous or mucinous, you are putting in the back of your mind that it's highly likely that it's going to be benign. serous cystadenoma or mucinous cystadenoma. This is the most common flavor for the serous and mucinous. However, the most common flavor of endometroid is the malignant and the clear cell. And that's why in the boards, they never test you in a benign endometroid or a benign endometrioma or benign endometroid lesion of the ovary. No, there's always endometroid adenocarcinoma or endometroid carcinoma of the ovary. It's always clear cell carcinoma of the ovary because they know that 99% of the cases of clear cells are malignant, so they test you in the common. Okay? So these are the things that I need you to memorize from this table, that serous and mucinous most likely come in the benign flavor. Endometroid and clear cell most commonly come in the malignant flavor. Brenner also comes most likely 99% as benign Brenner tumor. And that's why you would never, ever encounter a questions in the board Q banks or in your board exam testing you about a malignant Brenner case. Oh, no. Okay. This table, we might come back at the end after we're done with the epithelial tumors, and I doubt we'll be done with them even in one session because they are taking over most of the notes. So let's start by the epithelial and the surface tumors. Let's start one by one. Let's start about the first word of the mnemonic, which is water. Water, serous. Water, serous. So what's the meaning of serous cells? Serous cells means ciliated fallopian tube-like cells. Well, do you see any features of malignancy here? Any mitosis? Any ugly-looking cells? The answer is no. So we have benign-looking, ciliated fallopian tube-like lining in a cyst, which is more than 1 centimeter in size, because if the same exact lining is existing in a cyst which is less than 1 centimeter in lining, what do we call it? Anybody can jump in? If it's less than 1 centimeter, what will we call it?
Cortical inclusion cyst.
We'll call it benign cortical inclusion cyst, right? So benign cortical inclusion cyst is the same as serous cystadenoma, but it's less than 1 centimeter in size, okay? So here you have the ciliated fallopian tube-like epithelial lining, no mitosis, no ugly-looking cells. In the lumen of the cyst, the content of the cyst is purely watery, it's purely serous, and the size is more than 1 centimeter in diameter, okay? What you need to know is that there is an important variant for the benign serous cystadenoma, in which you have the exact same lining, the exact same ciliated fallopian tube-like lining is here. But on low power, you see that there is some kind of stromal expansion. See? The stroma is expanded a little bit. There is a little bit of extensive fibrous exophytic stroma due to stromal expansion, making finger-like stromal fronds or finger-like stromal undulations. However, the lining of the tube is not expanded. There is no stratification in the lining, nothing. The expansion is only in the stroma, in the fibrous component. They call it serous cyst adenoma. No, it's serous cyst adenofibroma, because you have like a fibroma component here. You have a stromal fibroma component. So they call it cystadenofibroma. Very boardable. They love it. 2-star diagnosis. 2 Q banks ask about the exact same picture and the exact same spot diagnosis thing. So you need to know it. Serous cystadenofibroma. Serous cystadenoma. It's a subtype of serous cystadenoma. Serous borderline tumor. See, you have the same serous epithelial lining. However, the cells are starting to proliferate a lot, to the point they start to throw in some papillae or throw in some branching tree-like branches. It's like tree-like branches. See the stroma here is in the middle here, and then you have like as if you have branches arising from a tree. So branching tree, and in this area of the branching tree, if you go high power, you will see that you're still seeing these columnar / cuboidal cells with minimal atypia, no mitosis, no ugly looking cells. However, the cells are extensively proliferating in the lumen of the cyst. It's proliferating in the lumen of the cyst. It's not showing any features of stromal invasion. It's not invading the ovarian stroma. The ovarian stroma is fine, but you see all these cells are growing and proliferating in the lumen, making a branching tree pattern. All columnar cuboidal cells, minimal atypia, no stromal invasion. And that's why for your practice, you need to sample the cyst very, very well. Anybody can tell me in summary, what do you do when you receive an ovarian cystectomy or oophorectomy for an ovarian cyst? What do you do in grossing? What do you do for grossing? You get like an ovarian cystectomy or oophorectomy, remove the whole ovary for ovarian cysts, and they need you to gross it. What do you do?
I guess I'll speak. No one is speaking.
Okay.
I did one, but it was huge, like more than 2 kilos. The ovary.
Yeah, the watermelon. I always call it.
Yeah. So I guess it was mucinous cyst adenoma or mucinous carcinoma. I don't remember the sign out part of it, but it was very huge. There's like a lot of whatever undulations or things inside with a lot of mucin. So I had to sample extensively, like in different areas, solid areas, and like
Okay,
mucinous areas.
that's one keyword. Solid areas. You need to
Yeah.
take as much sections as possible from the areas which look solid, because when you have like a solid or a small solid frond or undulation in the lumen, this means that you are highly likely having some kind of extensive epithelial proliferation at this site. So you need to take a representative from this side and make sure that you're not dealing with any malignant looking cells, or you're not dealing with any stromal invasion at this site. So, but you have to ink at first, right?
Yeah, of course, this is the thing. Yeah.
So measure, weight, and ink. That's the
Yep.
first thing. Measure, weight, and ink. Okay, so we ink the outer surface, and then you open and look at the content, right? And after you open and look at the content, you start submitting representatives from the solid or papillary or finger-like areas, okay? Submit as much representatives as possible. Well, how much is enough? Do you
I
know?
guess what one per each centimeter.
Yes, one section per each centimeter. Good job. So if the cyst is like, let's say 10 centimeters, so you need to submit 10 representatives at least. And the 10 representatives, and in the 10 representatives, you should include the cyst lining and the cyst wall, the ink. And preferably, you take the sections from the solid / papillary / finger-like areas, okay? That's how we say we properly sample. That's what I mean by sample well, okay? So that's what I mean by here, by saying sample well. So in case in all the areas, you only see the proliferation towards the lumen, finger-like, tree-like, columnar, cuboidal, not ugly looking, kind of in between being benign and malignant, and there is no stromal invasion, you're good to go to call this a borderline serous tumor. Still serous, remember, there is no mucin here, there is no mucinous here. Remember these two. They are commonly asked in the Q banks. The RA, the two molecular mutations which exist in borderline serous. While I call it the RA, because see, RA, I always say B, RAF, KRAS. They commonly exist together in a lot of tumors. I always call them the RAs. The RAs because you have BRAF, KRAS, the RAs. So RAs are there in the serous borderline tumor. Please make sure that you remember that. Sometimes they spread and send peritoneal implants. Make sure you know that even a borderline serous tumor sending peritoneal implants, you can't call it serous carcinoma. Still, it's borderline. To call it serous carcinoma, you need to have evidence of ovarian stromal invasion. However, borderline serous tumors, they might send by themselves some peritoneal implants without being carcinoma or without being a frank carcinoma. And this is how he talks about the implants. He says some kind of extra ovarian spread of serous borderline tumor. So see, they call it extra ovarian spread of serous borderline tumor. So they don't call it a serous borderline carcinoma. You will have some kind of peritoneal implants which look exactly the same as the primary ovarian tumor look, and there is no destructive invasion. It's just a space occupying peritoneal nodule which is respecting the surrounding and it's not infiltrating in the peritoneal fat. See, he say even that you can have some desmoplasia and they call it desmoplastic implant, yet they still don't call this as a serous carcinoma. They still call it as a serous borderline tumor. So you need to have the fact in your mind that the serous borderline tumor can spread to the peritoneum by sending some kind of peritoneal implants, and the prognosis here is dependent on the stage, whether it sent any peritoneal implants or not. If it's limited to the ovary, very good prognosis. If there is peritoneal implants, this increases the risk that it might be actually a carcinoma, or there is a high risk of recurrence after removal. Okay? All right. So that's the serous borderline tumors. He sometimes call it the cauliflower. And it looks like a cauliflower, I agree. These kind of things look like, a lot of them in the lumen, they look like a cauliflower, honestly. Then talk about the, he added, I think, this entity. This entity was not there, I think, in the previous version. Let me double check, hold on. No, it was there, but it didn't have this picture. It didn't have this evil head picture. So he's saying that this is called serous borderline tumor, muco or micropapillary or cribriform subtype. I've never found it in the boards, and he even mentioned that this doesn't have any prognostic value, or it doesn't add anything to the prognosis of the patient. However, in here, instead of having these branching tree-like proliferations of cells, no, the cells here are proliferating in a kind of micropapillary pattern or micropapillary architecture. You know what micropapillary architecture means? Means that the cells are forming pseudopapillae. These finger-like things, they are not true papillae. There is no fibrovascular core. That's pseudopapillae. And some cells start ripping off from the surface, producing some circular balls of cells in the lumen. It's as if you're ripping off some cells from the top and they are floating there, or they're thrown there in the lumen. That's what micropapillary architecture means. This is micropapillary variant of serous borderline tumor. You still see the serous borderline, but the cells, instead of proliferating in a tree-like way, they proliferate in a finger-like way, or a finger-like architecture. See, as before, but the cells form micropapillae. And to call this kind or call this variant, you have to have this architecture occupying more than ½ centimeter of the cysts. And see, the key microscopic fact here for the micropapillae that it's usually taller than wider. It's 5x taller than wider. Not very important, not really important. That's why he's putting this evil head with snakes coming out from the head. Snakes, because the snakes are taller than wider, so it's kind of the same. It's kind of look the same. Serous carcinoma. What do you have in serous carcinoma? Low-grade serous, high-grade serous. Low-grade serous, when you see low-grade cells, see? These cells are low-grade. No mitosis, no atypia. The atypia is not that much. The mitosis is not very obvious and very prominent. However, these cells are invading the ovarian stroma. See, here the ovarian stroma, and it's invaded by the nests of cells. See this? You have sometimes single cells, nests of cells, sending seeds inside the stroma, showing stromal invasion. If I see stromal invasion, this equal carcinoma. Carcinoma of the ovary. Look at the cells. Are they serous or mucinous? They are serous. So that's serous carcinoma. Then look at the cells again. Are they low grade or high grade? Is there abundant mitosis? Is there abundant atypia or not? Well, low mitosis, low atypia. So this means that you're dealing with a low grade serous carcinoma of the ovary. The low grade serous carcinoma of the ovary is the most common tumor that you might see samuma bodies in the ovary. It's like papillary carcinoma of the thyroid. This is also low-grade serous carcinoma or low-grade papillary serous carcinoma of the ovary. You might see some muma bodies. Also in meningioma and mesothelioma, you see also some muma bodies. So this is the only tumor that you might see some muma bodies, which are these like concentric calcification bodies. You might see it there. See, moderate cytological atypia, low mitotic activity. However, there is stromal invasion. It has the exact same mutations as the serous borderline tumor, which are the RAs, BRAF, KRAS. Just remember these. Sometimes the invasion is actually a micro-invasion. What's the meaning of micro-invasion? Less than 0.5 centimeter. We get used to that. We had also micro-invasive cervical carcinoma, if you remember, which the area of invasion is just less than 0.5 centimeter. Sometimes they consider this as non-invasive, actually, some of the clinicians. Then high-grade serous carcinoma. Oh, okay. This is the most common ovarian carcinoma. This means it's very boardable, very testable. Well, I see serous cells or mucinous cells. Well, no mucin. I don't see any mucin here. So are the cells invading the stroma or not? Yes, they are. That's the stroma here. And the cells are dipping down in the stroma. And you might see some nests of these cells here and there inside the ovarian stroma. Okay, so look at the cells carefully. Well, they are serous. Are they high grade or low grade? Yes, they are high grade. High grade means high mitosis, high atypia. See, this is one mitosis. That's another mitosis, I believe. A lot of mitosis here and there. Here. So that's a lot of mitosis. And when you look at the cells at high power, see how extremely these cells are atypical. See how atypical these cells are. Oh, there is a lot of nuclear pleomorphism, a lot of high NC ratio, and a lot of prominent nucleoli. So you're dealing with highly atypical cells, maybe multi-nucleoli even in some cells here. So, well, we are having high grade. So stromal invasion equal carcinoma, serous cells equal serous, high grade is high grade, so high grade serous carcinoma. High grade serous carcinoma, most common ovarian carcinoma. It usually happens in older women and it usually comes in an advanced stage. Most of these cancers send peritoneal seedings before they get discovered. Before they are caught, they are usually already there in the peritoneum. and you have to remove. Actually, classically, they remove the omentum. Oh, no problem, Hike. No problem. Oh, Heba. Heba is saying that she need to leave. All right. No problem. No problem. I will post this recorded session on the YouTube as always, you know. So it's usually in the older women. It's usually come in advanced stage, and it send metastasis to the peritoneum already. Yeah, just remember this. The same exact two stains or two IHCs that we use for the high-grade serous carcinoma of the uterus, of the endometrium, we use them here. Anybody can tell me what are the two stains that we used to use to identify the high-grade serous carcinoma of the endometrium? Haik or Aliya or anyone other than Abdurrahman? Because Abdurrahman will feel like I'm targeting him all the time.
B16 and B53.
Yeah, P16 and P53. Good job. So we mentioned that P53 would be mutant and P16 would be strongly positive or block positive. Same thing is happening here. No change. See, you have some patterns which are repeating itself. So TP53 mutation is there nearly always. So you have P53 overexpressed or null, which is a mutant. And P16 is strongly positive, right? Yes. Abdurrahman is saying you are. You are targeting me. Okay, thank you. Just also memorize, please, that the high-grade serous carcinoma of the ovary is the most common ovarian cancer happening not only in the ovaries in general, but it's the most common ovarian cancer happening in those who have BRCA mutation or BRCA mutation. So BRCA mutation equals breast cancers, ovarian cancers, hereditary breast cancers, hereditary ovarian cancers, premature. It happened in very young age. So you'll need to remove the breasts and remove the ovary prophylactically. That's why they call it prophylactic salpingo-oophorectomy. So you need to remove the fallopian tubes, and you need to remove the fallopian tubes in the ovary, and you need to remove also the breast. So these are the BRCA mutation or BRCA 1 and 2. Very high risk of high-grade serous carcinoma. This is just for the sake of tumor boards and for the sake of clinical practice. It's not really for the boards, however, as long as I highlighted it, so this means that you need to remember it. Most of the high-grade serous carcinomas of the ovary, they arise originally from the fallopian tube. They start always in the fallopian tube, and then they go to both the ovary and the endometrium sometimes. But always the origin is the fallopian tube. And that's why in any salpingo-oophorectomy spasm, which turned out to be high-grade serous carcinoma, you need to submit the fallopian tube entirely. And you need to submit thin sections of the fallopian tube to examine under the microscope very carefully. Because if you see the high-grade serous cells sitting there in the fallopian tube, this is called stick. This is called stick. Stick means serous tubal intraepithelial carcinoma. This stick carcinoma is actually high-grade serous carcinoma of the fallopian tube, and it usually makes its way to the ovary and makes its way sometimes to the endometrium. So always the origin here is the fallopian tube. So let's say you are in the tumor boards. This is very common in GYN tumor boards in our institute. We have such a heavy GYN service in our program. We get like the 3 ovaries, sometimes 2 uteruses a day. So it's too much. We have such a heavy GYN service. So we get exposed to a lot of ovarian cysts and a lot of this stuff. So you have like a case in which they remove the uterus, bilateral fallopian tubes and ovaries, okay, for high-grade serous carcinoma. And you have high-grade serous carcinoma in the endometrium, fallopian tube, and the ovary. and they are asking you, are these 3 primary tumors, or is it a tumor and it's going somewhere else? Like they need you to let them know whether this is actually 3 primaries or is it 1 primary and making its way to both. You always respond by saying, well, I don't know, I can't make it for sure, but most of the time, common is common. The most common thing, it came from the fallopian tube and it made its way to the ovary and the endometrium. And this is what we call stick carcinoma or serous tubal intraepithelial carcinoma. Make sure you examine the fallopian tube very carefully in each high-grade serous carcinoma case. And if you see any suspicious cells in the fallopian tube, do the P53 stain and do the P16 stain to confirm that this is actually high-grade serous carcinoma. Okay, that's a table to compare the low-grade and high-grade serous carcinoma. You can go over this table, but just I want you to memorize that this is BRAF, KRAS, like the borderline, but this is P53 and BRCA mutation. The cutoff for the mitosis, if you want to know a number, it's 12 per 10 high power field. If it's less than or equal 12 per high power field, this is low mitosis. If it's more than 12 per high power field, per 10 high power fields, it's high mitosis. The pleomorphic nuclei, here uniform rounded to oval nuclei. Okay? That's it for the serous. So everyone, thumbs up for the serous carcinomas of the ovary. So benign serous cystadenoma, borderline serous tumor, and high-grade serous carcinoma, or low-grade and high-grade serous carcinoma. So now we know all the entities. Now let's move on to the mucinous. Mucinous, this means I see mucin. I see mucinous epithelium. The mucinous epithelium always look like GI epithelium. It looks like either foveolar epithelium of the stomach or looks like colon epithelium, like the one that you find in colonic acini. What are the types? What are the flavors? Well, we have the benign flavor, borderline flavor, and malignant flavor, as always. So we have mucinous cystadenoma, borderline mucinous tumor, and mucinous cystadenocarcinoma. All of them you have. Let's start by the mucinous cystadenoma. Well, I see one layer of mucinous cells with mucinous content. The content of the cyst is purely mucinous. However, I don't see any tufting. I don't see any tree-like branchings, and I don't see any papillae. The epithelium is just a single layer, no stromal invasion, very benign looking, no mitosis, no atypia. That's mucinous cystadenoma. It's usually unilateral. It has a wide age range. However, the average age is always old age, like 50, in the 50s. It's usually cystic, have a lot of mucin inside, and it's showing always minimal atypia with very rare mitosis. The molecular here is KRAS only, frequent KRAS mutation. There is no BRAF. So mucinous KRAS only. Serous KRAS BRAF. Just make sure you memorize these kind of things. Well, what about mucinous borderline tumor? Same thing. So as before, like I see the mucinous epithelium, benign looking or benignish looking, because it's starting to turn malignant, but still no mitosis. However, there is extensive epithelial proliferation to the point that you see tufting, like these finger-like things or finger-like tufts, or you might see papillae with papillae or tufting, tree-like branching, but all mucinous. All the lining show mucin on the top, like these mucin vacuoles on the top. So this means that we're dealing with mucinous borderline tumor. Is there any stromal invasion? You should let me know. Is there any stromal invasion that you see? Anyone on the chat, anything? Is it a yes or a no? Any stromal invasion? Well, the
Doesn't look like
answer is
one.
the answer is definitely no. No stromal invasion is allowed here because we're still in borderline category. We're not in invasive or mucinous cystadenocarcinoma. Okay, for the borderline mucinous, it's also unilateral. It's usually multicystic. You have this mucinous epithelium with mild to moderate nuclear atypia. That's why I say benignish looking. However, still low mitosis. There is some kind of architectural complexity. This means tufting or papillae. Okay, you might have some micro invasion if it's less than 0.5 centimeter of invasive carcinoma. They always consider this the same as borderline mucinous tumor. They don't consider it as invasive mucinous cystadenocarcinoma. And it also show only KRAS mutation, no BRAF. Just for your practice, it might progress anywhere to mucinous carcinoma or mucinous cystadenocarcinoma or invasive mucinous carcinoma. And that's why you need to sample the cyst very, very well. What I mean by a very well sampling is to submit one section, at least one section per centimeter, take sections from solid areas and areas showing tufting or papillae, and have a full section including the lining, the stroma, and the cyst wall. Okay? Then we have finally mucinous carcinoma. Mucinous carcinoma is the same as before. What I mean by as before is as borderline. So we still get this tufting, we still have these papillae, and we have extensive proliferation of mucinous epithelial cells. However, we are having now stromal invasion, and the cells are very high-grade looking cells. The problem here is a problem. The problem is sometimes when the mucinous epithelial cells becomes high grade, they sometimes lose its mucin, or the mucin gets very depleted in the cell because the cell is becoming nearly entirely occupied by a nucleus, by an enlarged nucleus with prominent nucleoli, making it a little bit tough to see mucin as clear as when you see it in the mucinous cystadenoma or the borderline mucinous tumor. However, please look carefully for any signs of any mucin, even if it's really depleted. Watch also for the cyst content, the content of the cyst, whether it's mucoid, mucinous, or is it serous, watery. This is very, very important because it gives you an idea of what you might end up dealing with. So what I might end up dealing with. Am I dealing with a serous tumor or mucinous tumor? So here we have destructive stromal invasion. Make sure you remember that. Most tumors in this case are usually confined to the ovary, has solid cystic areas, usually unilateral, and it happened in old-aged females. The same exact introduction. However, you have some kind of expansile glandular growth, and there is destructive stromal invasion. See here? This is high power of endometrial stroma. This is stroma, actually. And these are the cells invading the stroma or infiltrating the stroma. See how high grade these cells are? How there is very prominent nucleolus and how there is nuclear pleomorphism and high NC ratio. So here there is cytological atypia, abundant mitosis, and you have the same KRAS mutation, but you add CDKN2A. CDKN2A. CDK is this cyclin-dependent kinase, which is one of the cell cycle proteins. So CDKN2A mutation. This, I think, the driving mutation which drive it to invasion or make it invade the stroma. Okay. Sometimes you call microinvasive. in case it's less than 0.5, as always. The prognosis here is very bad, very poor. But it depends on a large degree whether it's confined to the ovary or did it send out to the peritoneum or send out any peritoneal implant. That's a very important table rule for your practice, but it's not for the boards as well. So I want to ask a question. Let's make it as a discussion, as an open discussion. Let me discuss this with Mariam, for example. Mariam, are you there?
Yes, yeah, I'm here.
Yeah, okay. So if you see mucinous epithelium, well, I understand that if you see this benign looking mucinous epithelial lining, single cell lining, and there is no tufting, no papillae, no mitosis, no stromal invasion, well, that's mucinous cystadenoma. It doesn't confuse at all. However, when you see invasive mucinous cells or invasive cells which still have some mucin there, and they are very high grade and invading the ovarian stroma, you might be thinking of mucinous carcinoma, right? However,
Right.
is it mucinous carcinoma of the ovary, or is it mucinous carcinoma of the colon and sending metastasis to the ovary, or is it mucinous carcinoma of the stomach sending metastasis to the ovary, or is it like mucinous carcinoma of the appendix sending metastasis to the ovary? What is, can you differentiate this on H&E, for example? Do you have a clue how we can like differentiate this on H&E or even on gross examination?
On H&E,
Let's say first on gross examination. On gross examination, which one will be bilateral and multiple?
yeah, usually as you show in the table also in metastatic we
Yeah, metastasis.
yeah.
So if it's highly likely, if I see like bilateral ovarian involvement and it's multiple sites or multiple foci of bilateral ovarian, well, it's highly likely to be metastatic. Okay,
Yeah.
metastatic coming from the stomach, coming from the colon, coming from whatever. However, if it's unilateral and it's like unifocal, that's highly likely to be a primary ovarian. But however, there is exceptions. What about H&E?
Yeah, in H&E,
What would you look for in an H&E?
I think in H&E we should look for with again I'm cheating, I'm using your table. So I think signet ring cells in
Signet ring cells. Signet ring cells could be metastatic, like coming
yeah.
from the stomach or coming from the colon, and highly likely from the stomach, by the way.
Yeah.
But this is not, if you try like to make up your mind a little bit, which one would have background ovarian epithelial change? Background ovarian epithelial change, what I mean is you will have the background borderline tumor there. See, like invasive mucinous carcinoma or invasive serous carcinoma, they don't come out of nowhere in the ovary. There is always some tufting.
Oh yeah, I got it. Yeah, I got it. Yeah,
It's
we
like
had
background change in
yes.
the ovarian epithelium. It's already there, and then it invaded. It's not coming from nowhere.
Yes.
However, in metastasis, you would see that the
It comes
ovarian
from
epithelium look intact, but there is something coming out of nowhere and just putting in some deposits in the ovarian stroma.
Actually, I had a case like this. Yeah, I got it.
That's how you think. This is actually not for the boards. Like this thing is not
yes,
for the
it's for
board,
practice. Yeah,
it's just for practice, so that you end up like, okay, these are the common questions that the attendings usually ask.
Yeah, exactly.
However, the other layer that you can use to confirm is IHC.
Yeah,
they might ask you, what's a good panel you can order in order to rule out this by IHC? This don't even bother looking at this table. This table will make you confused.
Okay.
Look down there. See, this is good panel. Highlight it. That's it. CK7, SAT-B2, PAX8. So you say we order CK7, PAX8, and SAT-B2. So the next question they will tell you, oh, why you order these three? You say, well, because CK7 and PAX8 would be strongly positive in ovarian. This confirmed ovarian origin, especially PAX8. And then SADB2 is a common immuno that rule out GI, or it's usually positive in the GI. Like it's positive in stomach, positive in appendix, positive in colon. So if I see SADB2 positivity and then CK7, PAX8 are not strongly positive or even negative, especially the PAX8, well, this means that it's coming from outside. But if I see CK7, PAX8 are positive and SADB2 is negative, this confirms that I'm dealing with a primary ovarian mucinous cancer. Okay, you got it?
Yes, yeah, thank you.
Yeah. So here is a question here. Heike is asking, how is CDX2 compared to SADB2? Both of them are really good. However, sometimes they order both. They order CDX2 and SADB2 because as you see here, SADB2 is negative in gastric, but CDX2 is positive in the whole three GIs. So sometimes they order both, but there is no such a comparison between CDX2 and SADB2. But both of them are good. But he's saying that this is a good panel. At least you order these three IHCs because CK7 would be strongly positive in ovarian. SADB2 would be strongly positive in lower GI, not of course in the upper GI because stomach in the upper GI. And PAX8 would be helpful if positive, but it's not always positive in primary ovarian. And that's why we complement it with CK7 because sometimes you might have PAX8 negative ovarian lesions. Okay, so that's the only thing that I need you to memorize from this whole thing. You don't need to bother yourself with this table, but of course it's good to read. And also he's talking here that in primary ovarian it's going to be unilateral, in the other one is going to be bilateral. The size in the primary ovarian would be larger than the metastatic deposits, which are usually smaller. The location here is in the primary ovarian, it would be within the stroma. However, you will see this background well-differentiated mucinous epithelium, borderline type, forming these tufts and these tree-like growth. However, here you will see only infiltrating cells out of nowhere. And most of the time they have signet ring appearance. And they are usually located within the ovarian surface / the stroma because they are usually coming from the peritoneum. They are coming by transcoelomic spread. Okay. Here, I don't know, this is too much. I didn't even look at this table, like comparing the primary ovarian mucinous borderline tumor, compare it to low-grade appendiceal mucinous neoplasm, which is the lemon. No, that's too much. You don't have to bother with this. See, I added this algorithm for ovarian cysts. This is how I approach any ovarian cyst in any oophorectomy case. So for any oophorectomy, I look at first at the lining. That's what I do. And grossly, ink, measure, and weight, and open. And look at the content. Collect, always open inside the container. Open inside the container in order to collect the content, the cyst content, and assess whether the cyst content is mucinous or serous. Then under the microscope, you look at the lining. Do you see any mucin in the lining? Yes, it's mucinous. No, it's serous. If you see a mix of cells, this is called seromucinous. We'll talk about this in the end. Don't bother right now. Then you ask yourself two questions. The first question is there any branching / tufting, tree-like growth? If yes, it's borderline or invasive. What determines which is which is, do you see any high-grade cells? Do you see abundant mitosis? Do you see stromal invasion or not? If you see them, that's high-grade carcinoma, high-grade mucinous, high-grade serous. High-grade mucinous, high-grade serous, depend on which type of cells you saw at the beginning. If it's a no, so no high-grade cells, no stromal invasion, so it's a borderline serous or borderline mucinous, depends. But if there is no branching or tufting, usually you won't see any high-grade cells. or any stromal invasion. And it would be usually a cystadenoma. Serous cystadenoma, mucinous cystadenoma, or seromucinous cystadenoma, depending on what lining you see, or what kind of cells you see. However, rarely, sometimes you might not see any tufting or any papillae, but this is extremely, extremely rare. But you still see high-grade cells and you still see stromal invasion. So it's still a high-grade carcinoma, but it's kind of a typical presentation because usually high-grade carcinoma come on top of borderline tumor. So you will usually see tufting and papillary architecture, tufting or branching or tree-like architecture. Okay, give me a thumbs up for this algorithm and for the serous mucinous. All right. All right, good. All good. Now the endometroid. So we're now done with serous, mucinous. We're now dealing with endometroid. Well, please. Benign endometroid. There is no such a thing that you call benign endometroid tumor of the ovary. No, it's a benign endometroid means benign endometrium. And when you see benign endometrium in the ovary, what do you call this? Anybody could jump in? It's called, yeah, it's called endometriosis, actually. So there is no such a thing that you call benign endometroid tumor. No, it's benign endometrium in the ovary. Benign endometrium in the ovary is just some ovarian endometriosis, some ovarian endometriotic implants that might make a cyst. And as we all know, that there is a kind of cyst which happen due to bleeding every month. Inside this focus of endometriosis, the blood starts to collect and make a cyst, and the blood starts to change its color because altered blood, it sits for a period of time, so it starts changing its color to brown, and they call it chocolate cyst or endometrioma or endometriotic cyst. Benign endometriotic cyst, benign endometrioma, chocolate cyst, all are the same here. They are benign endometriosis or benign endometrium in the ovary. They arise on top of the benign endometrium in the ovary. That's benign. That's common. It happened in middle-aged females, the menstruating females. It's just a cystic form of endometriosis. It's not neoplastic. I added a picture for this in the next page so that you can see it here. Like I added it because he didn't add any pictures. See, this is the ovarian stroma here. And you see out of nowhere, you see endometrial glands, which are very benign looking, and endometrial stroma, which is also very benign looking. That's endometriosis focus or endometriotic foci in the ovary. How do we highlight the stroma? Anybody can jump in and tell me? From the benign endometrium. CD what?
CD10.
10.
CD10. And how do we highlight the endometrial glands?
ER.
Yes, ER. ER for endometrial glands, CD10 for endometrial stroma. Make sure you remember these. Okay. That's endometriotic cyst, endometrioma, chocolate cyst. In chocolate cyst, you might end up seeing, of course, some bleeding or hemorrhage or some hemosiderin-laden macrophage. Hemosiderin-laden macrophage. Okay. The most important thing that I need you to know is endometroid borderline tumor / endometroid carcinoma. And just letting you know, the boardable entity is endometroid carcinoma. But just the base that you need to know in these, that endometroid borderline tumor / endometroid carcinoma of the ovary, both of them arise on top of endometriotic foci. These are just some endometriotic foci which undergo malignant transformation and made an endometroid tumor in the ovary. So because physiologically there is no endometrium in the ovary, if you see endometroid cancer in the ovary, this means that it arises on top of endometriotic focus or endometriotic foci. So, like any benign endometrium, can anybody remember what's the sequence of endometroid carcinoma? So you start with benign endometrium, right? And then you become benign endometrium, and then second
Hyperplasia?
step is, yes, endometrial hyperplasia, and then the third step is endometroid carcinoma, right? These are the three stages of the three-step ladder approach, or the three steps of the ladder of endometroid adenocarcinoma. Same thing is happening here. Like endometroid borderline tumor is actually endometrial hyperplasia in the ovary. So when you see endometrial glands, but they are not malignant looking, but they are increased in number. You see a lot of endometrial glands, and still there is abundant endometrial stroma in between, but the gland to stroma ratio is 2:1. That's endometroid borderline tumor. So endometroid borderline tumor, see, in summary, it's endometrial hyperplasia in the ovary. And there's no stromal invasion of the ovary. There's no invasion of the stroma in the ovary, because you still see benign endometrial glands, but they are high in number. And there's still stroma in between this gland. However, the gland to stroma ratio is high, is 2:1. See, he's saying it resembles atypical hyperplasia / endometrial intraepithelial neoplasia. There is no stromal invasion. It's also associated with endometriosis. The prognosis here is excellent. There is no destructive stromal invasion. However, endometroid carcinoma is the same exact picture you see in the endometrium. Back-to-back glands, cribriforming, no intervening stroma in between, and invasion of ovarian stroma surrounding. Invasion of the surrounding ovarian stroma. See these glands? Oh my God, this is nearly fused glands, to the point that you see the cribriforming? That's the cribriforming. That's what we mean by cribriforming, with back-to-back / fused glands, no stroma in between these glands, as you see here. There is no stroma in between the glands, and there is invasion of the surrounding ovarian stroma. How do you know that this stroma is invaded? Anybody can tell me from this picture? How do you know that this stroma is invaded? What's the one word that?
Is it like surrounding the stroma, or you mean like immunotherapy?
Yeah, this stroma here. Why do you think that this stroma is invaded, and, for example, this stroma is not invaded? How can we tell that this is invaded or this is not invaded under the microscope?
Desmoplasia.
Yeah, exactly. That's the word that I need to hear, actually. This is desmoplasia, stromal desmoplastic response. See here, there is a lot of inflammation, a lot of chronic inflammatory cell infiltrate, a lot of lymphocytes here. This means that you're having reactive desmoplasia. Highly likely you're having stromal invasion, aside from the pattern of endometrial glands that you see with cribriforming and loss of intervening stroma and back-to-back glands. That's it. Deal. It's endometroid adenocarcinoma. Endometroid adenocarcinoma is the malignant flavor of endometroid carcinoma of the ovaries. It's also, of course, associated with endometriosis. Where the hell the endometrium will come from? It resembles what you see in the endometrial cavity. You see back-to-back glands, confluent, cribriforming, destructive growth, and you sometimes see squamous morules, some mucinous metaplasia, like what we see. And even it's the exact same molecular of the endometroid adenocarcinoma. Remember APC, A stands for ARID1, ARID1, and P stands for P53 and PIK3CA. And then the C stands for catenin, beta-catenin, beta-catenin. So it's catenin. So APPC, these are the classic molecular mutations that's there in the endometroid. Well, Alia is asking me to explain about desmoplasia again. Yeah, I used to have the exact same question when I was PGY1. And you didn't start your residency yet, so it makes sense that you don't know what desmoplasia is. Well, desmoplasia is reactive stromal inflammation. Because you know, Alia, if you unmute your mic for just 1 minute, or
Okay.
yeah, so Alia, when there is invasion by cancer, like when cancer invades the stroma, this leads to kind of stromal necrosis, right?
Yes.
Because you are just like invading it by tumor cells. So that's why necrosis leads to reactive inflammation, right? There is always reactive inflammation in response to necrosis. So you see that in the stroma. You see that the stroma is infiltrated by inflammatory cells. Heavy inflammatory cellular infiltrate in the stroma means that this stroma is getting invaded by something.
I understand.
There's
Thank you.
some kind. That's what we call desmoplasia as pathologists. And we always say desmoplasia in tumor boards, and some clinicians, especially the surgeons, they don't care what desmoplasia is. They keep like shaking their heads, and that. Yes, I see that. Yeah, so it's APPC. So APPC, remember this: ARID1, P53, PIK, 3CA, and catenin, beta catenin. Usually ERPR positive, P53 wild type, and P16 negative. This is the signature, the IHC signature for endometroid adenocarcinoma, right? Lastly, clear cell. So now we're done with half of the notes. Exactly. We're halfway. Okay, so lastly, clear cell carcinoma. Please don't even bother reading clear cell cystadenoma or clear cell borderline tumor. I'm sorry. That's a waste of time. See, he's saying it's extremely rare. He's like making it all caps as if he's shouting. It's extremely rare. So he's telling you that, oh, don't bother about these entities. If there is any clear cell tumor in the ovary, it's gonna be clear cell carcinoma. Can anybody tell me the scheme for clear cell carcinoma?
Napsin A, HNF1 beta.
Yeah, napsin A, HNF1 beta, and I see nests of clear cells with some kind of fibrous septi in between, right? So it's the exact same freaking scheme that we'll keep repeating over and over again until you remember it by heart. That's malignant. Yes, it's malignant. It's also associated with endometriosis for some reason. So I already mentioned this, I think, when I was explaining the endometrial tumors. I think I said the two endometrial cancers which are associated with endometrial hyperplasia are clear cell carcinoma and endometroid adenocarcinoma. Same thing here. Endometriosis / endometrial hyperplasia, they are also associated with endometroid carcinoma of the ovary and clear cell carcinoma of the ovary. It's kind of clear cell change on top of endometroid. They are thinking that way. It's high grade. Yes, it's high grade. You see clear cells. Well, I see clear cells, pleomorphic, hyperchromatic, showing malignant feature. See clear cells in any architecture. In any architecture, I mean the clear cells could have nested architecture in nests. They might form papillae. Don't bother. You still see clear cells. If I still see clear cells, so I need to add these two IHC in order to confirm the clear cell carcinoma, which are HNF1 beta and napsin A. Molecular wise, it shows some of the mutations of the endometroid, and that's why they believe that both of them is a common origin. It's kind of morphological change, or they call it like a change, a phenotypic change. So they both show ARID1, which is ARID1, and PICA. Abdurrahman, you know, in Arabic, this is, I know that Haikwood is we call this urid.
I want.
Yeah, urid means I want, but in Arabic, that's how we memorize it. And this is bika. You know, Bika, the guy who sings, he's an Egyptian singer, by the way, but he
Oh.
yeah, you know, so Arid and Bika. So this is in Arabic actually. So I remember them this way. These are the two mutations, the common mutations in Endometroid. Okay, so that's clear cell. All right. So anybody have any questions? Let's try to make some discussion here because we'll do the worksheet next time, because next time we'll finalize the ovarian tumors and then we'll move on to the worksheet. Next time is gonna be like a little big lecture, so just be prepared. But let's discuss. So let me first discuss with Alia, since I just finished with Abdurrahman.
Okay.
Alia, what do you think? What do you think? So if I see a single layer
Mm-hmm.
of fallopian tube-like cells, no mucin, and the size of the cyst is less than 1 centimeter.
Inclusion.
Yes, cortical
Okay.
inclusion cyst.
Yeah.
Cortical inclusion cyst. That's cortical inclusion cyst. Height. What if it is more than 1 centimeter? What if the same cyst is more than 1 centimeter? Like single layer, fallopian tube-like cells, no mucin, so no mucinous cells, and there is no malignant features, no stromal invasion, nothing, and it's huge, more than 1 centimeter. What do you call it? What do you think?
Oh, sorry, I'm blinking on the name. It's together benign.
Yeah, benign. Is it serous or mucinous?
It's serous.
Yeah, benign, serous, and cystadenoma. Cystadenoma if benign, cystadenocarcinoma if it's malignant, right? So it's benign,
Yes.
serous, cystadenoma. Good job. Okay. Then Mariam, what do you think if I see tufts, branchings, there is areas of solid or areas which have like papillary features in the growth, and I took sections from the lumen to the wall, and I see the papillary tufting and the tree-like arborizations of cells. The cells are still, the cells have mucin, so there is mucin inside the cells, and there is stromal invasion with reactive stromal dysplasia, and there is a lot of invasive foci there. So what would you call it?
I will call it Mucinous carcinoma.
Yes, mucinous carcinoma of the ovary. Good job. So if I need an IHC to exclude GI,
CDX2
yeah,
and
CDX2 and SADB2. Good
yes,
job.
SADB2
CDX2 and SADB2.
and
So this is to exclude GI and to prove
CK7 and TAX8.
Good job. Good job. Abdurrahman, yeah, what do you think if I see stratified, I see a huge ovarian cyst, and then I took a representative and inked the wall, but I see, all what I see is just like stratified layer, very thick stratified layer of some benign looking cells with some luteinization and a hemorrhage inside.
Hemorrhagic corpus luteum
That's
cyst.
that's hemorrhagic corpus luteum cyst. It's physiological incidental that happen in a lot of females, and highly likely it's there in benign ovaries.
Yeah, and follicular if it's less in stratification.
Yeah, if less stratification, it is follicular. Yeah, good job. All right, so lastly, we will go for Alia again. So Alia, can you enumerate the I'd say this germ cell tumors? Can you try? Can you try to do the full?
Yeah, this germinoma,
Yes.
teratoma, embryoma, choriocarcinoma, and yolk sac
Yolk sac
tumor.
tumor. Just it's not embryoma, it's embryonal carcinoma. It's called
Embryonal.
embryonal. Yeah, all right. So that's the 5 types of germ cell tumor. What about the 5 types of epithelial tumors?
Mucinous, serous,
Serous,
Branner
Brenner.
tumor. What else?
The 2 things that we took at the end. Endometroid
Endometroid and clear cell. Yeah.
and the clear cell. Yeah, endometroid. It's okay. It's okay. It's fine. The mental block is always there. You know. Yeah. So what about Hayek? Any if you see benign endometrium with hemosiderin-laden macrophage and hemorrhage in an ovarian cyst, this is called benign endometrium with hemosiderin-laden macrophage and some kind of hemorrhage in the cyst, and it looks brown always.
Oh, the chocolate cyst. Oh
Yeah,
yeah,
that's the chocolate cyst. That's what we call endometrioma, right? Which
you're
arise,
right.
yeah, which arise always on top of endometriosis. All right, so Abdurrahman, if we see the back-to-back glands with stromal invasion in the ovary, which look like endometroid adenocarcinoma of the endometrium, and you need to rule out serous, what are the immunos you will order? You need to make sure that this is not actually, because the glands are very solid to the point that you don't know if this is high-grade serous carcinoma of the ovary or is it like endometroid carcinoma of the ovary. Which immunos you will order?
Wait a minute. It's not B16 and B53, right?
No, it's not. This is to rule out mucinous. But what's the combo that we use to differentiate serous from endometroid?
Napsin, and it
Nope.
that's for clear
Nope.
cell.
That's for clear cells. Anybody can jump in, help Abdurrahman?
Maybe WT1.
WT1, not there yet, but it's good. Yeah, WT1 we can order. But who else? Yeah, Mariam, you have anything?
P53 maybe?
Yes, P53 and P16 and ERPR. Please remember these 4.
I just asked it if it's B16 and B53, and you said it's mucinous.
Oh, really? You said P16, P53, or you said SAD-B2?
No, I said B16 and B53.
Oh, sorry. So my fault then.
No,
So
it's fine.
We'll check the recording later.
Yeah. We have evidence.
So it's mutant in the endometrioid or it's in endometrioid, right?
So yeah, so let's go one by one. For the ERPR, which one will be strongly positive? The endometrioid or the serous?
It has to be endometrioid.
Endometrioid, of course, yeah, because it's more towards the endometrial side. And P53 and P16, which one would show wild type P53 and negative P16?
I guess it's serous.
No, it's endometrioid also.
Oh, okay.
I tricked you. It's also endometrioid.
I'm confused at this one, so it's fine.
Yeah. So make sure you know that these 4 immunos we order routinely for all GYN tumors, like endometroid/serous. We order them by default. So it's always there. So just to let you memorize, ERP, the endometroid adenocarcinoma will show ER positive, PR positive, P53 wild type, and P16 negative.
Well, I guess I'm just gonna remember it as endometrioid ER/PR positive and serous P16 and P53 positive,
yes,
which is the block and the mutant type.
So, but in high-grade serous, ER/PR are negative, and P53 would be mutant, which is either strongly positive or null.
Negative. Yeah.
Right? And P16 is gonna be block positive. Okay.
Mm-hmm.
So I know GYN is a little tough, but we are getting there, right?
I think so.
Yeah, we're getting there. Just make sure, try to read and reinforce, read and reinforce. Try to like highlight the key words that I always say, that highlight the key words, write down the key microscopic fact on each picture, and then do a fast jumping by your eye and look at the key microscopic feature and let your eye jump and read the key facts in each entity. You will get there. You'll get there with like 3-4 revisions. You'll be good. Questions, you will smash it. You will master it. So it's gonna be fine. All right. Thank you very much. I appreciate it, and
Would
I
you-
will see you
Would you
tomorrow.
mind? Would you mind
Yes.
sending the
I'm planning to send it, but once we are done for yeah, okay. So you know what? I have an idea. I will cut the part that we took today and send it. Okay, so that you read in parallel. Yeah, I agree. All right, sure. So I will make sure I send the modified notes to everyone. Thank you very much, and we will get in touch tomorrow. I think I'm planning to continue with ovarian tumors tomorrow, so that we finish it in one shot. All right.
Thank you.
Thank you
Yeah,
very
thank you
much.
so much.
Thank you. See you. See you all tomorrow. Thank you. Bye. Bye.
Bye.